Good afternoon. I'm Katie Bowler-Young. I'm the Assistant Dean for Communications, Marketing, and Business Development at Duke University School of Nursing, and it's a pleasure to welcome you to the Building Upon Excellence Dean's Lecture Series featuring Dean Vincent Guilamo-Ramos. I am going to share just a couple of logistical details about how this event is unfolding to make things easier on your end. If you are interested in turning on closed captioning, at the bottom of your Zoom preference screen, you can click on an icon to turn on the closed caption live transcript. There is an automatic closed captioning. Additionally, today, we're able to offer this lecture interpreted in Spanish as well. And so you'll see an icon that looks like a globe and the word interpretation. If you click on that, you will see the option to listen in Spanish. So thank you. I hope that you enjoy the program. I'm now going to turn this over to Professor Karen Reuter-Rice.
Hello, it's my pleasure to welcome you to the first lecture in the 2021-2022 Dean's Lecture Series. Today's lecture builds upon this fall's successful Building Upon Excellence presentation that was widely attended by our alumni, school community, and friends. The Dean's Lecture Series will feature speakers throughout the academic years to connect our Duke University School of Nursing community, alumni, school partners, and friends with experts and educators on topics that address the evolving role of nurses in healthcare, new models of nurse-driven healthcare delivery, and future directions in nursing research and education. I am pleased to introduce Dean Vincent Ramos, who is both Dean and Professor of the Duke University School of Nursing and Vice Chancellor for Nursing Affairs, Duke University. He is also the founding director of the Center for Latino Adolescent and Family Health at Duke University. Dean Ramos is widely regarded as an expert, scholar, and leader in adolescent and young adult sexual and reproductive health. Promotion and his research has been funded for 2 decades by National Institutes of Health, Center for Disease Control, Health Resources and Services Administration, and other federal agencies. His research focuses on the role of families in promoting adolescent and young adult health among Latinos and in other underserved communities, with a special focus on preventing HIV/AIDS, sexually transmitted infections, and improving care outcomes for youth receiving HIV prevention and care services. Dean Ramos serves as a member of the Presidential Advisory Council on HIV/AIDS, the Health and Human Services Panel on Antiretroviral Guidelines for Adolescents and Adults, the CDC and HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment. He also serves on the Latino Commission on AIDS Board of Directors as Vice Chair, the Power to Decide Board of Directors, and co-chairs the Ending the HIV Epidemic Working Group on HIV Medicine Association. Please join me in welcoming Dean Ramos.
Thank you very much, Karen and Katie, for that wonderful introduction. Hello, everyone. I am going to start by saying thank you to students, to faculty, to alumni, to friends of Doosan for being here today. I'm very excited to be kicking off this first lecture in the Dean's Lecture Series. And I'm particularly excited because I am in New York City. You can notice in my background that I'm sitting at the NASDAQ building in Times Square, where we just had a wonderful experience where Doosan partnered with a number of key private sector companies, including OraSure and NASDAQ, to really recognize World AIDS Day, which is tomorrow. So I'm actually here, and I just want to acknowledge that tomorrow is World AIDS Day. I'm going to share my screen and actually start my presentation. So I'm hopeful that you all can see that. And so today I'm going to talk about social determinants of health. And as Karen shared, the focus is really to have a series of conversations here at our school about topics that are relevant to health broadly, but also relevant to nurses and the nursing profession. Over the course of this academic year and next academic year, we're going to engage in a series of conversations where we can critically think together about ways that we can leverage nurses to really address some of the most pressing health and social challenges that we're facing. The format will be symposia, and there'll be a number of expert speakers and innovators who will be leading those discussions. Today, I have the honor and pleasure of being the first speaker. And today, what I'm hoping to do is to actually talk about social determinants of health. But before I do that, I just want to share some of the other topics. You can see here in this puzzle, this was part of the State of the School address that was just a few weeks ago. But some of the upcoming lectures are depicted by the other pieces. The next one will be on the nursing workforce. But for today, I really want to focus on social determinants of health. And I have a number of goals. The first is really to help us to think about this critical moment that we're in. The last time that I had the opportunity to speak with this group, I reflected on the slide that you are currently viewing. And this slide really sort of depicts the current landscape and what's happening in terms of healthcare. There have been significant changes that have been sort of really impacting health broadly and disparities and inequities. And you can see here that these significant changes have taken the form of what some call large-scale transformative events. And some of the examples that stand out, at least that are the most compelling in my view, are actually depicted in the figure. But you can see the COVID-19 global pandemic, issues like structural racism, what's happening in terms of migration in the border, and then also broader issues like the climate and how the climate is impacting health. And so I'm offering this because I think we're in a particular moment where nursing is really thinking about these contemporary challenges. And I'm really happy to share this slide, which I also shared at the State of the School address, because nursing has been leading the way. You know, nurses have been thinking critically about possible solutions to preparing our workforce, to sort of imagining our educational programs, our research enterprise, to really respond to the contemporary challenges that we're facing in healthcare. And so for today, I'm going to offer sort of my take on one particular aspect of what I think Doosan and other schools of nursing should be thinking about, and that's really social determinants of health. There are three things that I'm hoping to accomplish. One is I'm going to talk about our current understanding of social determinants of health. I think here I'm going to review some things that probably most of us are familiar with, but I'm going to point out some things that I see as being opportunities and places where I guess I would ask us to pause and question, does this really make sense? And should we be thinking about social determinants from a slightly different angle? I'm also going to start introducing this notion of mechanisms, and that social determinants of health have particular mechanisms, and that there are some principles. These principles will be very important to the presentation. They will really highlight some of the large theories, and there will be exemplars of evidence that goes along with these principles and some of the theoretical contributions that have been depicted in the literature. And I think the part that I'm most excited about is really putting forward for our Doosan community and for our friends to really think through, what does a framework for addressing social determinants of health look like if it's nurse-led? And what is Doosan uniquely positioned to really be able to contribute in this ever-emerging important space? And so I'm going to start with some information that, again, probably most of us know, but I think it just makes sense to maybe remind us and use some of this early part of the presentation to highlight a couple of points. And so you can see here that the United States has the lowest life expectancy, but the highest healthcare expenditure relative to other developed nations. And so if you look at those two columns in red, one is the US and our life expectancy, roughly 77.3 years, versus our expenditures and the percent of our GDP. And you can see that by far we have the lowest life expectancy and the highest healthcare expenditure. I think what's striking is that as I was preparing the presentation, what really sort of illumined and was quite overwhelming in my view was the US combined annual health and social expenditures, that it exceeds $4 trillion. And what was really sort of interesting to me, and that I hope will help us to sort of think about some of what I'm going to be sharing in subsequent slides, is this disconnect, this misalignment between where we're spending our money and where we have opportunity to actually have the greatest impact. And so there's misalignment with modifiable determinants of health. And you can see on the left-hand side that 53% of our funding is really spent on clinical care, both inpatient and outpatient. About 30% is on other aspects of health, which includes home care, nursing home, medical goods. But 3% of the 4 trillion is spent on prevention, and 14% is spent on social care, social spending. That excludes retirement and health expenditure. But again, the smallest segment is really focused on the areas where we have the potential for major impact. On the right-hand side of the slide, you can see the relative importance of modifiable determinants of health. And I guess the point is that that misalignment is quite pronounced when you consider what's on the right-hand side. So 50% of the modifiable determinants of health are really associated with social and economic factors, or socioeconomic and environmental factors. You can see 30% are lifestyle factors, and that clinical care is important, but it represents a smaller proportion of the overall. 80% is socioeconomic, environmental, and lifestyle. You can see here that there are sort of 4 areas or 3 areas that are highlighted by the boxes, and these are the modifiable determinants of health. And you can see that lifestyle and behavior is 30%, as I depicted in the previous slide, and the kinds of things that are associated with lifestyle and behavior: diet and exercise, our alcohol and drug consumption, tobacco use. Our clinical care, we certainly have the ability to improve access and quality of care. But then below, you can see environmental and socioeconomic, which is really the bulk of the percent in terms of the modifiable terms of health. And you can see that things like education, employment, income, family support, housing, that these are areas that sort of are consistent with this particular domain, and that there is an unequal distribution both of resources and attention, and that this unequal distribution really produces health inequities. There are some traditional ways that we have tried to understand disparities and inequities. And I guess this is an important point. So I'm going to spend the moment really highlighting this. So the first is that we've had a tendency to really embrace paradigms that characterize disparities by sociodemographic factors. And so often when we think about aggregate data, we actually are reading about a particular health disparity, and the way that it gets characterized is that certain groups, whether it be Latinos or African Americans or whites, that group has this particular disparity, or sometimes it's by socioeconomic status or by gender or by sex, but we tend to really think about sociodemographics as a way of characterizing, as opposed to really thinking about, are there underlying drivers of health disparities and inequities? And maybe that a sort of greater potential opportunity for us is to think about these underlying drivers versus to focus on the sociodemographic factors being somehow predictive of a given outcome. There's also a tendency to view health disparities and to sort of talk about vulnerable communities. And so it's often the case that we start describing certain groups or certain sociodemographic segments as being vulnerable. And so the use of the term vulnerable also sort of really minimizes the focus on important social processes as being explanatory, and really notions of exposure and susceptibility are absent. And I'll talk about that more in subsequent slides. But I'm going to suggest that an over-reliance on sociodemographics and a tendency to focus on communities as being vulnerable is probably not the way that we want to move forward. Another important point is a tendency to view health disparities from what I'm calling a deficiency-focused perspective. And here, what I mean is, often the question, whether it's explicit or implicit, is why are communities doing so poorly? And so if you add 1, 2, and 3 together, typically the questions might be, why are certain sociodemographic communities doing so poorly? And so you might argue, well, why is the Latino community vulnerable and doing so poorly? Versus really thinking through what might the response be if we asked ourselves the question, why do communities do as well? Or how do they do as well, despite all the challenges, right? And so it acknowledges that resilience is an important factor and moves from really thinking about a sociodemographic, a vulnerable population or community, a deficiency perspective, to really acknowledging resilience, underlining processes, and also this important role of exposure and susceptibility. If we think about HHS and Healthy People 2030, this is the social determinants of health framework. Probably most of us are pretty familiar with this. But again, what I notice when I look at this is that there are some important aspects of environment, socioeconomics, lifestyle that are depicted here, but they seem pretty static to me. And so education, access, and quality, healthcare and quality, neighborhood and the built environment, et cetera. And what typically happens in a lot of the literature is that we have a social determinant, much like what we saw on the previous slide, let's say, for example, neighborhood and the built environment. And we tend to correlate that with a particular disparity. And so we start characterizing certain kinds of neighborhoods or communities or certain kinds of educational contexts as being predictive of certain outcomes. And that for a long time has been what the literature has advanced. And I think what's important about that is that from that literature, this notion of vulnerability as an important mediator has been also advocated or advanced. And I think here, this idea again of vulnerable communities, and that what we see is that communities that are experiencing health inequities, primarily along racial, ethnic, socioeconomic, sexual orientation, gender identity lines, that they typically get characterized as being vulnerable and therefore having the health disparity. I wonder if we were to consider social processes and really thinking about interactions between persons, groups, or systems, if we also think about exposure, and exposure as being something that's environmental, and that really is a condition that is really being impacted in terms of risk or a protective factor that is exogenous to the individual, that it's in the environment. Susceptibility, that really susceptibility is biological, and that exposures can actually interact with susceptibility to produce vulnerability, and also resilience, and the idea that how are particular groups of people, communities, populations able to thrive despite adversity? And I guess what I'm trying to suggest here is that our current conceptualizations, what's depicted at the top of the slide, that they often lack some of the core points that I'm making on the bottom of the slide. And so I'd like to introduce that. And I guess what I'd like to share is that I was reading a paper very recently in the American Journal of Public Health, terrific, scientific journal. And what I loved about the article, you can see the citation on the bottom of the slide, was that there was an introduction of this notion of resilience, exposure, and susceptibility. And vulnerability was not seen as being fundamentally related to a social determinant of health, but that social determinants of health actually impact social processes, and social processes impact social determinants of health, which in turn affect exposure, the likelihood that somebody will come into contact with a risk or protective factor, and also a biological process, which is susceptibility. And that when those two things come together, they create vulnerability. And that throughout all of this is resilience, the ability to either thrive or not, despite whatever adversity we're experiencing. What I like about this is that it moves beyond a simple conceptualization of the social determinant of health on impacting a given health disparity. So I'm going to talk about mechanisms, and I'm going to pull this together in an applied example that's relevant for nursing. And so I think first and foremost, I want to acknowledge, and this surprised me, I started thinking about this presentation some months ago. And I think the first step was to do a quick search in PubMed and some of the other databases. And what was interesting was that when you put social determinants of health into PubMed, at that time, 14,252 hits came up. And what was striking is that initially I thought about going through each of these to see what I could distill for this presentation. But what I walked away with was that back in 1961, that was the first article that, at least in my search, mentioned social determinants of health. But it wasn't until 2010 that I started to see that there was this real escalation and this increase. And you can see here that in 2010, there were roughly 164 results that came up. But then after that, there's been a steady increase. And it's really been in the last decade that we're seeing much more attention to social determinants of health. And so in that sense, it actually made my sort of review literature much more focused on the past decade. And so when I think about the past decade, this is sort of an overview of the major landmark mechanisms and principles that emerge from that literature. And so I'm going to review each of these, and then I'm going to make an application and a strong argument for why Doosan and nursing are very well positioned to address these. And so I'm not going to go through this slide too much because I'm about to talk about each of these principles. So the first is really fundamental causes theory. And so this was advanced by Joe Phelan and Bruce Link. And here, this was a landmark theory that moved beyond individual risk. Believe it or not, up until the time when fundamental cause theory was really advanced, there was this notion of risk factor epidemiology. And the attention was really focused on these proximal determinants of a particular health disparity. Really, what fundamental causes theory did is that it identified distal factors or exposures as really being tied to a particular outcome or health inequity, and that these distal factors or exposures were classified as fundamental causes. These fundamental causes are important because they disrupt access to resources, and they can minimize the chances that we're able to mitigate the effects of that distal factor on a given outcome. At the time, there was a lot of discussion in literature about how do these fundamental causes, how do they enact their influence on a given outcome? And a lot of what was written at this time was that the mechanisms were complex. There wasn't a lot of precision in really being able to understand how we could better understand the pathway by which a social determinant or a fundamental cause achieves sort of a given outcome. And so there was also a sense that it was difficult to measure and to quantify the total effects of these fundamental causes. You can see here a good example is that one of the landmark studies is that for mortality, for preventable deaths, mortality was significantly associated with education. So in other words, if your death was preventable, then education and your educational level played an important role in predicting whether or not you lived. Rhodes was the next major scholar that was depicted in the literature. And what you see here is this notion of the risk environment. So Rhodes was probably one of my favorite theorists, because really what was being conceptualized was this idea that risk wasn't indigenous to the person, and that it wasn't about solely these things that were sort of, part of the individual, but there was a broader environment, a context, and that this risk was exogenous. It was outside of the individual, and that social situations, structures, places, that they shape a given outcome. And what I love about Rhodes is that there were 4 types of influences that really represent or constitute the risk environment. And you can see on the bottom of the slide, the physical space, the actual structures, the building, the way that things are organized, the social arrangements, the economic, and then policies. And that these things, they interact in ways that they actually can support health or they can compromise health outcomes. And so here is the first time that we started getting a sense that there was a tale of different contexts or different communities. And what this slide is depicting is community A, which has 2 sharks, and community B that has more sharks. And what that was suggesting is that if an individual were to go swimming in community A and do the same exact thing in community B, the chances of getting bitten by a shark in community B were much greater for reasons that you can see on the slide. Up until this time, it may seem simplistic what I just said, but really the literature really focused heavily on risk as being a function of individuals. And really what Rhodes was adding was this notion that context matters. You can see here that Rhodes also articulated that there was 3 levels of influence. There was a micro level, the action of individuals, and so whether or not you jump in that pool and you swim, but there was also this broader notion of the meso level. There are institutions like healthcare, like schools, like other institutions in our communities and society that can either facilitate or actually advance positive or negative health outcomes. And there was a broader societal piece that was the macro level, and that the types of influence and the levels of influence needed to be understood in order for us to effectively sort of change some of the negative outcomes that we've seen in terms of health inequity and health disparities. I think what's also important here is that Rhodes started to introduce this notion that disadvantage or social determinants of health, that they were not deterministic. It wasn't a one-to-one outcome. And there was a tale of 2 swimmers, a great example. So you can see swimmer A jumps into a community where there are sharks. And if you notice both swimmer A and B, there's the same prevalence of sharks. And so this is building on Rhodes's idea with another important concept. In this case, it isn't just that the communities have different prevalence of sharks, but at the meso level, one community has a lifeguard and medical care, there are resources. And at the micro level, this particular individual may choose to not swim on the deep end of the pool. And on the sort of the shallow side of the pool, there are fewer sharks. Where swimmer B is in the pool with all the sharks, there are fewer resources in terms of healthcare and a lifeguard and is swimming on the deep side. And that when you think of these 3 things, the prevalence of the sharks in the community is potentially being unequal, the kinds of services at the meso level that are provided, and then also individual actors and the decisions and behaviors that we engage in or not, that those things come together to actually shape a given outcome. Rhodes argues that we need to conduct a structural analysis. And so this is one that will just highlight briefly and say that if we think about COVID-19 and associated deaths in the Bronx, the community where I'm from, you can see that at all 4 levels, or 4 types of influence: the physical, the social, the economic, and the political, and the levels of influence, the micro, the meso, and the macro, that there is something that is identified, whether it be the availability of affordable housing, the neighborhood and household density, and then also the individual's exposure to COVID-19 in that community, that we can start to get insights into how there is a production of risk that is not solely explained by individual level factors. You see here a number of theorists, including Marmot, who have advanced a life course perspective, that it isn't just that these things are influencing us at a particular time in our life, but the social, the economic, the psychological, and environmental influences, they accumulate over the life course and they shape important outcomes, including our early life exposures. They impact later what happens in life, and that there was also importance of a temporal context and also spatial dynamics. This is a great example. One of the reasons why I love working with adolescents is that you can see in the left-hand corner that about 70% of the global premature adult mortality, so roughly 70% of premature deaths among adults across our globe, are associated with processes that initiate in adolescence. And so again, oftentimes we think of adolescents as being at the peak of their health, which is in most cases true. But we fail to recognize that a lot of what we see later on in terms of morbidity and mortality is tied to processes that begin during adolescence. This is an empirical study that supports that. You can see here adult outcomes in terms of adult sexual health and substance use. And you can see as a predictor, adolescent family connectedness and adolescent school connectedness as important adolescent predictors that later had implications for adult outcomes. And the tables are depicting sexual health and also substance use. Biological embedding is a Hertzman's theory, another important contribution. And this really fascinated me because this was an area that I learned more about in my nursing training, and really was an opportunity to understand that there's a biological process that social conditions can initiate and be sustained through these biological changes. And so when we have a social determinant of health, particularly one where there's significant adversity, that can have a profound impact on epigenetic, on neurodevelopmental, and immune and endocrine, and that those alterations are stable and long-term, and that we can see that over the course of our lives that these processes that we're experiencing are shaping not just the social or the environmental space, but they actually have an impact on the biology of the individual over the life course. You can see here a good example from a paper that was published in 2020 that really looks at childhood psychosocial adversity. And what's really nice about this paper is that you can see that childhood psychosocial adversity impacts biological changes in the epigenetic, in the neurodevelopmental, also in sort of the endocrine, and that in turn shapes adult outcomes. And you can see here that there are certain diseases that can be shaped by things that actually have their origins in early childhood. Another question that often comes up is, well, what about decision making? And so there are some folks that might feel like, well, people make choices about whether or not they engage in particular behaviors. And so what's really powerful about biological embedding is that you can see here that even at the level of our decision making, that there's a role of how social determinants and the processes, for example, early life adversity impacts stress, which results in inflammation, which results in more dysphoric feelings and impacts our affect and also our reward sensitivity and our expectancies or beliefs. And how we feel and how we think shapes our decisions regarding risk behavior. And so what's so important about this is that it's really showing that the biological vulnerability and also how these social processes and these social determinants of health are shaping our decisions. This happens over time. This embedding is dynamic, there are ongoing interactions, and it's not, again, at a particular point in time. And what's nice about this slide is that we're starting to see the integration of biological embedding with some of the previous literature around the different levels, right? So the political economy, the social structures, the neighborhoods, the interpersonal relationships. And you can see that there's recognition that there are different types of influences, different levels of influence, that biological embedding is shaping sort of ongoing dynamic sort of interactions, and that those things have important implications for poor negative health outcomes. And so you can see here that there's accelerated metabolic aging, and that's associated with neighborhood disadvantage. And so the more disadvantaged your neighborhood, the more your chronological age is inconsistent with your cardiometabolic age. And so we see people who are younger, who live in neighborhoods of great disadvantage with cardiometabolic aging that would be more synonymous with someone who's much older. So you can see here another framework from Hoke and McDade, which is around biosocial inheritance. And biosocial inheritance really thinks about the processes by which social adversity is transmitted across generations and through mechanisms, both biological and social. And so you can see here the cross-generational, which is from a parent to a fetus, the next generation. You can see here the multi-generational, which really speaks to the idea of a family. And so you have a particular family, but in that family, you have multiple generations, and that family may be experiencing certain kinds of social determinants that when the process is enacted, there are certain kinds of influences that result in changes that are negative in terms of the outcomes that we care about. And so again, we see notions of epigenetic, immune, metabolic, et cetera, and also social. And you can see here the transgenerational really is about effects that cut across different generations of a family. So we have mother to child, we have within a family, the different generations, and then we have across different generations of a family. So I'm going to just give some examples. And so here you can see example number one really is this cross-generational. And so this really looks at women to their children. And you can see here that US women of reproductive age in the lowest quartiles of SES are 2 times as likely to have exposure to phthalates as compared to the highest quartile of SES. And why is that important? That this exposure, which is in all sorts of things like plastics, vinyl floors, et cetera, that it actually has an adverse health effect on children, including their birth weight, their gestational age, their preterm birth, diabetes and asthma. And you can see the mechanism, the biological mechanism on the bottom, that low SES is sort of associated or correlated with increased exposure. That then impacts the child through methylation. There's an off switch that doesn't allow for the positive benefits, and there's a negative health outcome. Another example is the multi-generational example, which really speaks to the idea of a family, and that's what you see on the far right. And you can see here that low SES in a particular family, that family may be purchasing certain kinds of food, certain kinds of carbohydrates, certain kinds of fresh fruits or vegetables or not, that they may be also a change in their microbiota because of the food choices that are tied to socioeconomics. And then that change in their microbiota in turn impacts things like obesity and cardiometabolic health broadly. And so again, it's this idea that these social determinants impact the entire household or unit. And the last relational form is really the transgenerational transmission of trauma. And here, what is being depicted and sort of the best evidence comes from these very large scale events like the Holocaust, where we see that there's a parent that's had this traumatic experience, that there's been an exposure at the parent level that has a direct impact on the parent. And you can see here that the parent may have certain kinds of symptoms or biological responses or disease conditions, but that in turn impacts the offspring, and that offspring can also have those same kinds of, affect and expectancy changes, genetic changes, and also some of the sort of health outcomes like depression, et cetera. Syndemic theory, Meryl Singer, an anthropologist, really started to identify this idea of synergy and clustering and raise questions about why is it that each of these sort of negative health disparities tend to cluster in certain groups, and that we see time and time again that the communities with the greatest disadvantage are those communities that have elevated rates of diabetes or HIV or depression or COVID-19 cases, hospitalizations, and deaths. And there was this notion that we needed to think about syndemic responses, and that there was probably again, back to this notion of some fundamental causes, and to the very beginning of where we started. These syndemic theories suggest that there's both a biological and a socio-contextual sort of mechanism. And you can see here some examples of synergy. So on the right, you can see in this paper, there was sort of the clustering effect that people with COVID-19 also who are sort of most likely to be impacted by COVID-19 were people who had greater sort of levels of obesity, structural racism, and that these things tended to cluster together. And then also the synergistic effect, you can see on the left-hand side that here, this is really fascinating data. These are monthly overdose deaths from 2016 to 2020. You can see that post-COVID, which is that red line, there was an increase in sort of mortality that was associated with overdose deaths. And you can see that on the sort of left-hand side, things were pretty stable for quite a long time. And then COVID came along, impacted certain communities, and that resulted in sort of the exacerbation of negative outcomes. Nancy Krieger really starts to adopt this sense of the eco-social framework. And here, eco-social theory capitalizes on this notion of health inequities as biological expressions of social processes. And so this is really interesting. And that what we're really seeing are that social processes impact us biologically. And there's this real commitment to thinking about things from the point of view of social injustice. And so the example that is in a lot of Krieger's work is really structural racism. And so here racism, it's obviously an exploitative and oppressive social process that has a direct impact on racial and ethnic social inequalities. And those inequalities have an impact on racial, ethnic health disparities. And so you can see here that it's dynamic, it's multi-level, there's a social pathway and a biological pathway. And again, Krieger builds on some of the biological embedding work that I've already discussed. And so you can see here two examples. You can see structural racism. There's a bit of a historical context from 1960 to 2006, but this is still pending and enduring today. This paper was published some time ago, but it's a landmark paper. It really showed that in Jim Crow states, that you can see that ethnic racial minorities had greater rates of mortality relative to other groups. And so whether they were in non-Jim Crow or for that matter, they were whites in Jim Crow or non-Jim Crow, you can see here that if you were white, that you pretty much were consistent, but if you were a person of color, that in a Jim Crow state, you had elevated mortality. What you can see here on the right-hand side around residential segregation, the slide is really depicting, again, this idea of survival, and that where there's greater residential segregation, that the gap, the difference between whites and blacks in terms of survival is greater. So the more segregated your community, the larger the gap is between whites and blacks and other persons of color in terms of survival. So where does all this go? I feel like I spent a lot of time talking about these principles, and I hope I haven't lost the audience. And what I'm hoping to do is talk about this now, pull it all together, but I wanted to take you down a path of really thinking about the literature and what the literature says and where I see some opportunities as being important ways forward. So these 8 principles, these mechanisms, to me, they really mean 2 things. One, we need to think about how do we integrate these social determinants principles into a unified framework that actually distinguishes nurses. And I'm going to say on this webinar today, the Duke University School of Nursing as being a leader in identifying effective ways of being able to address social determinants from a nursing perspective. And so one thing I'm going to hope to do in the next couple of minutes is talk about integration. And then also, can we conceptualize what would an applied mitigation approach look like if it were nurse-led? What could we do given the mechanisms and all that we've learned in the past decade plus around social determinants of health? So here is a conceptual framework that I've been working on with my research group at the Center for Latino Adolescent and Family Health here at Doosan. And what is being depicted in the slide is really each of the principles have been incorporated into an organizing framework. And I won't go through all of this, but what I will highlight is that you can see the pieces are all there. You can see the micro, the meso, and the macro. You can see this idea of the life course. You can see that there are mechanisms and pathways that are operating in terms of social determinants, that there are social processes, that exposure plays an important role, as does biological mechanisms within susceptibility, that resilience and questions regarding why are communities or populations or groups doing so well given the adversity. And that also it's not about a given outcome, but it's about thinking through how do these processes and what you see depicted in the slide, how do they impact multiple outcomes? And how does this work within the family context, which has been the focus of my work for several decades? And are there implications not just for one generation, but across generations and transgenerationally? If I think about the principles that I've laid out, there are a couple of implications that I think are important for nurses in terms of mitigation. And so the first is underlining causes. So one approach for mitigation would be really thinking through meaningful community engagement and identifying through data priorities regarding disparities and drivers of those disparities. And so again, many of us at a school like Doosan who are involved in important research are thinking about a data-driven approach to identifying the drivers of those disparities and what are the most pressing problems that we want to address as a nursing workforce. context matters and that there is a production of risk that is embedded in that context. And certainly individuals play a part of that, but it's not only the individual, it's the meso level and the macro level, and that we need to think about moving away from solely a centralized prevention or treatment model, but thinking about decentralized community-based care that is tailored to a given context. I'm happy to report that 4 out of 10 nurses nationally are thinking about or are currently working in a context that is not the point of care at the bedside in the hospital. That's not to say that we absolutely need nurses who can work at the bedside, but we also need nurses who can work in decentralized contexts where we can tailor our care and our prevention to the context, and we can partner with communities in meaningful ways. The environmental disadvantage is not deterministic. There are things that we can do. We can foster important partnerships that amplify protective and resilience factors, and we can focus on multiple levels. That social determinants influence us over the course of our lives, and so we need to be proactive. That prevention and health promotion really should be a central focus for nursing. It already is, but we can even advance that further as opposed to reactive and thinking about treatment once people develop those negative health outcomes. That biological embedding is an important concept and that we need to leverage biological markers. I'm happy to share that a number of faculty at Tucson are already doing this, are looking at important biological markers and how do those biological markers, how do they enact their influence over time, and how can we think about coupling understanding those biological markers to prevention strategies that we can actually mitigate early on before folks start developing those negative health outcomes. That we need to think about social determinants as operating intergenerationally. And so again, the importance of thinking about healthcare prevention and health promotion from a family-based perspective and really adopting this notion that people exist in families, whether they be our biological families or our families of choice, but most of us are members of a family, and that family is an important context for helping our health promotion, prevention, and our care. That we need to think about comprehensive and interdisciplinary team-based care from a value-based framework, that obviously social determinants cluster and that they interact synergistically. And the best way of dealing with the clustering and with the synergistic effects is by having all hands on deck. It's a comprehensive interdisciplinary team-based approach. I want to suggest, and I really believe this, that part of that team is nurse leadership, and that increasingly it is the time, it is the moment for nurses to really rightfully assume leadership roles in responding to social determinants of health. And that social injustices and structural racism shape the impact of negative health outcomes. And so again, we need to think about moving away from a deficiency-focused perspective where we're simply characterizing why is it that certain communities are doing so poorly. And to me, in my view, the worst offense of this is to simply rely on sociodemographic factors to characterize groups, but to start asking, why is it that communities, that certain groups, that populations are doing so well despite adversity, despite the challenges? And how can we put these things together into a comprehensive package that will have the impact of really shaping important outcomes that we all care about? And so, no surprise, nurses are the largest segment of our health and public health workforce, more than 4 million in our country. There is no other health segment that is larger than the nursing workforce. I know I've said that many times, and I'm going to continue saying that because I think we need to sound that sort of alarm, hit that bell, a tap on that drum, whatever the expression is, to really get folks to understand that the vast majority of healthcare across our planet is delivered by nurses. We are indispensable in terms of scale and reach and effectiveness. It's not just that we're the largest, is that there is no way forward globally at being able to scale up health if we don't rely on nurses. There's no way to reach all the populations and communities that we need to reach if we don't embrace nurses. and that it's not just about the reach and the scale, but nurse-led interventions have been proven time and time again to be effective, and oftentimes more effective. And what's really nice about this is that close to 20 years, nurses have been time and time again identified as the most trusted profession. I mean, that's just important to pause and acknowledge. The most trusted profession, the largest segment, and indispensable in terms of scale, reach, and effectiveness. We have clinical care expertise. We are comfortable working in decentralized and centralized care contexts. We are experts at coordination of care. We are really clear about whole person perspectives to health. We are not treating a disease. We have a person in front of us, and we are comfortable with locational flexibility. We are the right workforce to significantly advance social determinants of health now and in the future. I think given all of the principles and all the things that I've laid out today in the presentation, the development of nurse-led, integrated, multi-level interventions that really think about not only the biomedical and the clinical, but move way beyond that into the psychosocial and also the structural, that we need to combine these in an integrated, evidence-informed way, and that these packages, these multi-level packages of interventions can be rolled out to scale by the nursing workforce along with other key partners to really advance our country's health and to reduce health inequities. Here's an example of a toolbox, and I think rather than go through all of each of the quadrants or each of the boxes in the toolbox, I'll leave this on the screen for a bit, and what I will sort of try to guide the audience to view is the color coding. And so you can see that the number 1 is structural, the number 2 is psychosocial, and the number 3 is biomedical. So in this sort of toolbox of a nurse-driven intervention, here are some components that actually might really come together in a way that would advance an evidence or a syndemic intervention that really is packaged at all 3 levels that would potentially have the impact of really shaping some of the negative outcomes that we see. What I like about it is that each of the principles is depicted in each of the quadrants, and so it pulls from the literature and identifies the mitigation approach with an actual specific nurse-driven sort of multi-level sort of intervention component. And so I like that very much. And so you can see, starting with community engagement and really thinking about identification of disparities in drivers and moving all the way to interdisciplinary team-based care, you can see that each of these boxes really describes and characterizes how we can collectively put together a package that would draw upon some of the biological markers, the family-based perspectives, the importance of thinking about resilience, the decentralized sort of community context, a proactive approach, and then also the importance of engaging partners and thinking about sort of how we can prioritize the drivers. And so in my view, this needs to happen over a series of steps. And I'm happy to say that at Doosan, there's a lot of terrific research that is currently taking place among the faculty and our doctoral students and others that really talks about what I've laid out in this presentation. And maybe the way the broader community thinks about their work might not necessarily fall within the way that I've organized it in the presentation today. But I'd like to invite folks to consider thinking about how your work relates to this. It's really an opportunity to invite our community to think about how your current research, is it really part of a formative intervention development phase? Are you really thinking about your role as sort of a partner in building relationships with communities? Are you working on needs assessments and prioritizing underlining drivers and disparities? Are you thinking about defining multi-level intervention components? Are you involved in implementation science and really aligning service delivery with community needs and priorities? Are we thinking about strengthening our health workforce and our educational programs that really identify inclusion and diversity as being very important, and the important role of positionality in our relationship to our communities? Are we involving community stakeholders and key partners and all hands on deck in order to advance sort of health and reducing health inequity. Our interventions, it's not enough to simply say that our interventions work or don't work. It's important to really think about explanatory trials where we can identify mediators and the pathways, the explanatory factors that really allow us to understand how they work. And then increasingly, and I'm really excited about this, I believe that we have a role in scaling up our interventions and really ensuring that there's a broad uptake, that there's impact, and we can engage policymakers, key decision makers, private sector, community partners to really ensure that the work that we're doing as a school and as a profession is having a broad impact on health. For me, there are 5 priorities for Doosan's role in positioning nurses as leaders in addressing the social determinants of health. And so this is sort of a bit of an image of our building. And so I hope that folks like it. It was sort of the best that we could do with the PowerPoint, but it's supposed to be our Pearson building. And you can see here that these 5 priorities are advancing the science of addressing social determinants of health, really being able to understand how we can dismantle structural racism, how we can incorporate notions of social injustice in health into our research, the prioritization of the development, the evaluation, and the dissemination of nurse-led, multi-level social determinant of health interventions. I had a terrific conversation with a group of faculty yesterday at the school where we were really talking about the importance of technology and how technology can facilitate health and well-being. And I think part of what my invitation to that group was to ponder and reflect on, is there a way to integrate this notion of nurse-led, multi-level interventions that are designed to directly address social determinants, but that incorporate many of the aspects, including technology, that we know are part of our current toolbox of research activities at the school. We need to think about new methods for really optimizing, scaling up, and reaching this notion of real world impact. I really want to highlight that we should be really sticking to not just discovery, but that we need to discover, we need to disseminate, and we need to scale up. It is important that we have real world impact, and that it's not enough to simply publish the paper in the journal article, that it is our responsibility as an applied profession, nurses, to have an impact on the health and well-being of real people in their real lives. And the last thing is that our education programs, our training, whether it be at the ABSN level, the master's programs, the DNP programs, or the PhD programs, that they all think about incorporating social determinants of health in ways that move beyond characterizations of particular populations as having certain kinds of fairly static social determinant kinds of factors. So, the person living with diabetes who has housing instability, that's a start. But I hope that what I have conveyed today in my presentation is really an invitation to think about some of these other dimensions: resilience, exposure, susceptibility, social processes, multi-level, life course, biological embedding. How can we start to think of these notions as being fundamental to our training, to the way that we think as nurses, and to the kinds of interventions that we sort of develop and that we disseminate as a profession? I'm going to stop my slide share. I'm going to thank you for listening to me. I hope that was interesting. I hope I was able to convey my thoughts clearly. I'm actually going to invite the audience to share questions or comments, and I'm going to look and see if any have come in. So I'm seeing a couple of questions that are coming in, and so I'm really excited. Katie, when she started the webinar today, she actually said that we were doing simultaneous translation in English and Spanish, which is terrific. And so everything that I'm saying in English is being translated in Spanish. And a special warm welcome to our colleagues in Mexico who are participating today. We have a large group in Mexico from the University UPAEP, which is in Puebla, Mexico, which has been a partner of CLAFS for many, many years. And so the first question is about how can nurses and other health practitioners influence intergenerational health outcomes of youth and young people who don't have the benefit of drawing on health promotion, prevention, and care from family. And so really great question. So what I would say is a couple of important pieces. First, I love that there's a sense of the family as being an important unit. And so I guess the challenge would be, how can we develop as nurses programs? And I've done this for a number of decades, where I have worked with families broadly. I'm doing it now with COVID-19. I'm doing a family-based intervention in the South Bronx, where community health workers and nurses are going door to door in public housing, and they're working with families on COVID mitigation, reducing exposure. They are mitigating susceptibility by doing health assessments on biological vulnerability. They are working on resilience and helping families to think about ways that, given the realities of their context, they can really avoid or reduce risk. And they're helping families to sort of build more mutual aid and help one another. I mean, to me, this is an example of how nurses can lead on social determinants, and speaks to the question that I see here on the screen from the anonymous attendee. Can I talk more about how educational programs in nursing and or other fields are changing curricula to be more inclusive? So I think there's been tremendous work. I know at Doosan, when I arrived, there was so much work that was happening sort of prior to George Floyd, but also post George Floyd, a tremendous escalation of consideration of all aspects of our school. And so I think more so than ever, if you think about those documents that I highlighted at the start of my talk, nursing as a profession, and certainly Doosan, is critically thinking about how do we incorporate social determinants into our curriculum? How do we think about equity, inclusion, diversity, social justice? They're an important fabric of who we are as nurses. I think there's recognition that we can do more, and there's also recognition that we're open and that we've actually done a lot already. Sally's saying thank you. And so I see that there are folks that are saying that they're connected. They're from the National Institute of Nurses in Mexico. So thank you, David, for being connected. We're so happy that you are here. So gracias, David, por estar con nosotros. Un placer tener mis colegas de México. Gracias por estar con nosotros hoy. We also have a comment from some internal folks at the school. Thank you for your recognition of the event as being a positive one. I'm seeing a question about I covered a lot of areas, and really about how widespread is our interest in nursing, and will nurses share with other clinicians and others. And so I think nurses, this is a question from Ed Hammond, I think nurses actually have been quite expert at working as part of multidisciplinary, transdisciplinary teams. I would say that really what I'm suggesting in the presentation is that not only are nurses part of teams, that's been going on for a long time. I think nurses are experts at being able to work in partnership with others. But there's this notion, Ed, of nurses as being leaders of teams. And some of that has happened, but there's more potential for nurses to really lead and to work alongside other health professionals. The truth is, we just don't have enough for example, physicians in our country to respond to the needs of people. Today, as I think about tomorrow being World AIDS Day, I came from a panel where we were speaking about some of the challenges in the future. We know that we have increasingly a population of individuals living with HIV who will need HIV and primary care for the rest of their lives. And the good news is that their lives will be healthy and long in many places like the United States, where there is access to antiretroviral treatment. The problem that we have is that we don't have a workforce that can actually care for individuals who are living with HIV in adequate numbers. And I would extend that beyond HIV and say we don't have a primary care workforce. We have a massive shortage. Well, nurses at the RN level, nurses at the NP level, boy, wouldn't it be terrific if we were able to somehow leverage that workforce to be able to better respond to the scale, the reach, and the efficacy of the health needs of the people of our country. I think that's really what I'm arguing for. And I think that the scope and the spread is actually quite broad, and quite broad because I think nurses are uniquely positioned to holistically respond to the whole person. So, so Barbara is asking a question or a comment about really acknowledging prenatal influences and stress. And so I think it's really important to sort of think about sort of Barbara's interests, which are around sort of women who are birthing and thinking about supports around pre-pregnancy and during pregnancy. And I absolutely agree with that. I think some of those relationships, Barbara, that I talked about, both from mother to child within a given family, and then also across generations of the family, to me, that's some exciting work. I think really speaks to the point that you're making. And so here, there's a question from Judith about what is the best methodological approach to prioritize funds into thinking about prevention. So I think that we need to address the most pressing problems. And that's something that I know NINR, that's Shannon Zank, who's the director of NINR, the National Institute for Nursing Research, has said time and time again since I've listened to her when she assumed her role as the director of NINR, that the most pressing problems that are shaping the vast majority of Americans in our country, that it is time to think about how we prioritize those and how we actually segment our interventions based on the disparities and the inequities, and that we start to think about putting forward these multi-level prevention and treatment packages that are novel and that start to really align with some of what we're seeing from our evaluation of the data. That hasn't happened, and sort of a good example of that is, again, I'll draw upon World AIDS Day, given where we are today. If we think about one of our most effective tools for preventing HIV, it's PrEP, it's pre-exposure prophylaxis. You know, there are several 100,000 individuals in our country that would benefit from having access to pre-exposure prophylaxis. You would think that the greatest uptake would be in communities with the highest prevalence of HIV, and yet we find that the lowest uptake and the people with the greatest number or the highest sort of need or greatest indications for PrEP are the least likely to be offered that. We need to start asking ourselves, how do we align our resources and our interventions with the problems that are most pressing and with the segments of our community that are in most in need. So Angela, thank you for being part of the presentation today. I see your comment and I appreciate you acknowledging that you enjoyed the lecture. You are saying that you're 72 years of age and that you're retired NP. Thank you so much for all your work, and that you are working in the Bay Area, that you worked in the Bay Area. And so thank you for being with us today. Andrew, thank you so much for your comments as well. Really important to have your support. And I'm getting a question from Pablo regarding immigrant communities and social determinants, and how could nursing work with migrant communities? And so Pablo, great question. I think that prior to my arrival at Duke on July 1st, a lot of my work was focused on the US-Mexico border, particularly in McAllen in Texas, and really looking at issues around migrants from Central America and Mexico to New York City. And I think a lot of the work that we did was really in partnership with the Catholic Church and really thinking about having decentralized models of care where we provided care directly within places like churches or sort of temporary shelters. That was the point of care was right there where we encountered migrants. I also am thinking about some of the phenomenal learning that I've had over the years with sort of the main partner that my research center has had in Mexico, UPAEP. We've had the ability to follow the train tracks in Spanish known as La Bestia that goes from sort of the southern border of Mexico, the northern border of Guatemala, straight to the United States. And along that train track, we've had the opportunity with colleagues in Mexico to actually work with the Red Cross and encounter migrants on the way to New York City and to the United States. And to provide care, whether it be some nutrition, whether it be a blanket, whether it be a social care around their rights as migrants in Mexico from Central America, whether it be hydration. These are issues, wound care because of folks walking miles and miles and miles and their shoes being damaged. And these are important life-saving interventions that I think nurses are uniquely positioned, Pablo, to provide that don't take place in the brick and mortar structures of health systems. And that's not to say that that isn't important, but they also have a profound impact on people's lives, at all different stages. I think that there are some additional questions. I'm just going to do a quick chime check. We still have a couple of minutes, and so I'm going to a little more. So Hudson Santos, who was formerly sort of a really important member of our community, completed a postdoc. And I would say, Hudson, it's so great to see your question because you are one of the foremost leaders who's emerging as doing a lot of this sort of biosocial work. And so your question is, can I speak more about preventing, stopping the origins of health disparities so that we can improve the health of the next generations? And so I think, again, Santos, hopefully my presentation has highlighted some of these points, but my view of this is that we need to have these multi-level intervention packages, sort of depicted like what was in that case, that has a clinical and a biological component, but also has a psychosocial and a structural that is really wedded to the family as an important context. And even when we're working with individuals, recognizing that they are probably part of a biological or a family of choice, and that becomes an important context to think through how to not only help them to manage and to address what they're currently experiencing, but to mitigate cumulative risk and cumulative vulnerability that comes from exposures and also susceptibility. And so I think a lot of the principles that I've tried to put forward in my presentation are how I would think about advancing work in this area. So let's see. And so I'm seeing Maria from Tabasco, Mexico. Gracias por estar con nosotros, Maria. I'm seeing Monica, who is a grad from the ABSM program in 2010. So Monica, thank you so much. You're currently working in FQHC in Ohio with a large Hispanic Latino population of migrant farm workers. Thank you. And you make us really, really proud. And we're so pleased that you joined us today. And so it's terrific. Chip Bailey, thank you, a faculty member from Doosan. It's great, Chip, that you're with us today. And so, Chip, the framework will be available through the slides. And so right now, it's sort of original thinking that my research group has put forward. We're in the process of writing a paper, but we sort of offer a citation on the bottom of the slide. Feel free to look at it and to actually reflect on it and to actually alter it. I would love for some members of our school to actually have some dialogue and discourse, and maybe we could collectively evolve the framework even further because it really reflects just my research group's thinking. So I'm seeing a question from Erica. So Erica Lieberman, who's asking, how can we effectively integrate social determinants of health, social justice, equity, teaching in our bachelor's level nursing program curricula? And so I think, in my view, I think social determinants and the kinds of thinking that I have put forward today, I think they're fundamental to all levels of our nursing education enterprise. And I would say that there is no better time than at the undergraduate level or that first professional nursing degree to really start to infuse these ideas in the minds of our future professional nurses. Really exciting time in nursing. I think that the Essentials and the Future of Nursing report and some of the other major significant documents that are shaping broadly not only Doosan's curriculum, but also nursing as a profession. I think that's what they're asking us to do, Erica. And I think they're asking us to integrate all of this content into what we do in our clinical training and how we develop our nursing workforce. And so I'm seeing a question from Doctora Maria de Lourdes Rosas, who is my major collaborator. Thank you, Doctora Lourdes, for being part of the webinar today. I know you're in Puebla with the students at UPAEP. And so I appreciate your leadership, and I appreciate your willingness to partner with Duke. We look forward to ongoing partnerships. Roy Thompson, one of our future graduates from our doctoral presentation, thank you for being here. And I'm seeing many, many more comments of congratulations. I think that I have a minute warning, which is maybe an opportunity for me to pause and maybe just say thank you to all of you for being here today. I hope sincerely that made sense. I hope that it inspires us collectively to engage in dialogue and to really think about what this means for nursing, but what this also means for Doosan. Thank you very much, and I appreciate all of your time.